been all of us walking over in a giant gaggle of people from the academic offices over to the hospital to see conference, which is a fun time for me because I get to chat with everybody on the way over. But I think we did a little bit of that chat in the Zoom breakout rooms. It was good to see everybody. I think the day is going well so far. We have yet to have a giant tech glitch, which just sounds like I'm asking for it, but we'll see how noon conference goes here. I hope your interviews went well. I hope that they were not stressful and that, as promised, your interviewers were there to ask you a couple of questions to help you think about how you fit into the program, but mostly so you'd have a chance to meet more of our faculty and just get a sense of, is this the right place for you? Because that really is the question of the day for everybody here. Noon conference today is our usual conference style. We've gotten used to doing virtual conferences because we have to, and probably will have to again more significantly over the winter. So this is just what you'd see. We do not have a special interview day case. This is just how we do it here, because I want you to actually know what it's like to be a resident at Colorado. This is what we do for conference 4 days a week. The Monday, Tuesday, Thursday, and Friday. Wednesdays are grant rounds. So they're subbed in by the Department of Medicine grant rounds. And so this will be noon conference, other than we would have, we'd be feeding you right now.
Thank you, Dr.
All right,
Connors.
I'll turn it over.
Great. Welcome everybody to conference. I'll be doing a couple of introductory slides, but before we get started, I wanted to let our presenter and discussants introduce themselves, starting with Anita.
Hi, everyone. My name's Anita. I'm a second-year internal medicine resident here. I went to medical school at University of Kansas. I think I saw one applicant who's from there, so rock chalk. And if you have any questions, you can let me know.
Rock chalk.
Hey.
Natalie, take it away.
All right. Hey, everyone. I'm Natalie Longino. I'm an intern here at CU in the PSTP program, so in the physician scientist track going into HEMONC. I couples matched with my husband, August, who maybe some of you just heard now on the call. And yeah, nice to meet you all.
Mike?
Hey guys, I'm Mike. I'm the second year as well. I also did the couples match, so if you have questions, feel free to let me know. I went to Georgetown, coming from the East Coast, so happy to answer any questions about that transition. Just looking forward to the case.
And then Tijana, our R3.
Hi everyone, I'm Tijana. I'm a third-year resident. I'm from the University of Arizona. I did not do the couples match, so if you have any questions, just let me know. But I'm also applying into pulmonary critical care this year.
Thank you all of you for being here today. I'm Sneha, one of the chief residents, excited to do this conference today. Just a quick announcement that if you're really interested in participating, feel free to send in chats, but for our applicants, we do not expect you to participate. It will in no way affect how we rank you. And so sit back, relax, and enjoy the conference. We wanted to say thank you from the chief residents and our residents here. We're so glad to have you all here at Colorado. And it was really impressive the extent to which we are interviewing from people across the country and some international candidates as well. So welcome. A little bit about our teaching conference structure. Like Dr. Connors said, pre-COVID, all of our conferences were in person and lunch was provided, which it still is. Now we've moved to daily virtual conferences. When we are able to, we still try and do teaching conferences if they're safe with masks in use. And then all of our conferences are posted on our YouTube channel for people to watch later if any emergent patient care had arisen. And so with that, we'll get started. And Danny, one of my co-chiefs, will share his screen. All right, and I'll let Anita take it over from here.
Okay, great. So we'll start with the chief complaint of fatigue and jaundice. So the HPI, this is a 70-year-old male. So he presented with about 3 months of fatigue, B symptoms, and jaundice. He noted having like subjective fevers, night sweats, and a 30-pound weight loss over the course of those 3 months.
So Right off the bat, as you guys know, I really like harping on clinical reasoning and developing illness scripts. And so just based on this information, I wanted to sort of open it up for Natalie first, in that, Natalie, what do you think might be the most sort of, or which is the least vague complaint that the patient has? And how do you think about your differential buckets for that complaint?
Yeah, great. So I think least vague symptoms to me, I guess I'm between two. No, I'd say jaundice to me is a little more specific and narrowing in on like a hepatic, most likely hepatic origin. Of course, you could also have jaundice from like hemolysis or something like that that would lead to increased bilirubin. But to me, that narrows it a bit more down than like the other B type symptoms, subjective fevers, night sweats, weight loss. That just makes me think kind of global systemic, I would really call it like inflammation. So the things that pop into my head are potentially, this is like a subacute presentation, so potentially like a chronic infection like TB, or a chronic fungus sort of infection versus like malignancy. Of course, I'm very biased. I think malignancy always, but that could lead to B symptoms, or like autoimmunity could lead to those things as well. But I think, yeah, the jaundice focuses me in the most there.
Fantastic. That's what I was thinking too. So great explanation. I think largely dividing it between, is this a liver intra or extrahepatic process, or is this not a liver process, meaning is this a blood process like? So great. So, all right, Anita.
Yeah, so we can go towards like more of the past medical history. It was pretty unremarkable. He had a past medical history of GERD and BPH.
And you can keep going with some of the other history stuff, and we'll sort of stop after surgical social and see if our discussants have any other questions for you.
Okay, awesome. So for his past surgical history, he had a right hemicolectomy a couple of years back. And then for his social history, he had a 30-pack year smoking history. He actually stopped smoking in those 3 months just because he overall wasn't feeling well, but no alcohol or drug use. And then for his medications, he wasn't on many meds. He was on Flomax, trospium twice a day, and then pantoprazole twice a day.
So now for all of the discussants, what other questions do you have for Anita? What thoughts are you having now before we move to some of the other parts of the case?
Hello, everyone. Thank you for letting us participate. My name is Jose, and I was wondering what was the reason for the right hemicolectomy?
Yeah, good question. It was secondary to a history of diverticulitis.
Anita, I'm curious, as we're thinking about like subacute chronic causes of weight loss and malignancy being a big category, how up to date is he on his like age appropriate cancer screenings?
Yeah, good question. That was kind of unclear. He wasn't like super plugged into the medical system. So I would say he wasn't like fully up to date on all the age appropriate cancer screening.
And then as far as his social history, I mean, reassuring that he doesn't have a history of heavy ETOH use or IV drug use that would suggest higher risk for HCV, thinking about obviously cirrhosis and risk factors for HCC. The other thought is any travel history. As Natalie pointed out, some of the other chronic infections that might cause kind of extra or intrahepatic presentations like this.
Yeah, no recent travel history. He was originally from Colorado Springs and hadn't left the country in a while, so.
There are a few more questions in the chat, Anita, that I'll give to you. How is his appetite?
He said his appetite wasn't great. It just, for over the past 3 months, he just would like try to eat, but then just really felt like he couldn't. So I think that also contributed to his weight loss. It just kind of decreased over those 3 months.
Any pertinent family history?
No. Family history non-contributory.
And then does he have any history of incarceration, homelessness, or tattoos?
No.
Any changes in the color of his stool or urine?
He did note having some diarrhea, but that seemed more like chronic and not acute, but really no changes in the color. And then he did note having some dark urine. So that's pretty much it.
Any blood in his stool?
No blood in his stool.
And then did he serve in the military?
Yes, he did. I don't recall what branch though.
This is not a classic question I would be asking most 70-year-old gentlemen, but sexual history, just in terms of thinking of risk factors there, and you know, any concern for like HIV or any other immunosuppressive state.
I didn't really get the sexual history, but really no concerning. I know he was like, he lived alone, but that's a good thought.
And Natalie, I really love that you asked your question, but then told us why you were asking the question, which I think is really important to do, because we can be asking a lot of questions, and if we don't know why we're asking them, it's not very useful. And then, does he have any history of ionizing radiation?
Not that I know of, but I did not ask that question specifically.
And some of the more sort of tricky things like that, we won't keep from you. If it's important, we'll tell you about it. Does the patient have any itching?
No, he didn't.
Okay. Natalie, Tijana, and Michael, go ahead.
Oh yeah, sorry. The one other thing I was thinking about when, I guess when I think about a jaundice patient, we're thinking about hyperbilirubinemia, and we're certainly asking a lot of questions about like intra and extrahepatic obstruction, but also if there's any reason that they would have increased red blood cell turnover. So I'm curious if like if he is going to have any evidence of anemia, but also any other malignancies that could cause something like a hemolytic anemia as well. I don't have any other specific questions that I'm trying to think of as far as anemia besides the one that's already been answered, that's generally like fatigue, but I guess along with that, like lightheadedness, dizziness with exertion.
I would just say like he just felt kind of overall just like generally not well, but didn't really like describe feeling like particularly lightheaded or dizzy. He just like was just like over the course of the 3 months, he just didn't really have a great appetite and just kind of felt off, which is why he decided to come in.
Okay, so let's, Anita, I'm gonna have you present the exam to us now.
Yeah, so let's start with the vitals. So on admission, his vital signs, he had a respiratory rate of 20. He had a temperature of 37.4, which is 99.4 in Fahrenheit. And his blood pressure was 128/73. And his pulse was 95. So for his exam, just generally, he was just chronically ill appearing, but wasn't in like an acute distress. For his head, eyes, like neck, throat exam, it was significant for scleral icterus. His heart and lungs were normal. His abdomen exam was also normal. And then for his neuro exam, he was alert and oriented, didn't really appreciate any focal like neuro deficits, like all of his cranial nerves were intact. His gait was normal. And then for his skin, he was jaundiced and it didn't appreciate any lower extremity edema. So overall, pretty an unremarkable exam minus the jaundice.
anything specific you're looking for on exam other than what Anita gave?
Any
Yep.
lymphadenopathy? Oh, sorry.
Yeah, good question. No lymphadenopathy.
And the only other thing would be looking for splenomegaly and making sure to do a pretty thorough abdominal exam as well, as also including the right upper quadrant.
Yeah, I did not appreciate any hepatomegaly or splenomegaly on his abdominal exam.
And do we know, have we validated that the 30-pound weight loss is truly that? Do we have weights?
Yeah, so per chart review, he did lose weight. I don't think it was like exactly 30 pounds, but he did lose, I think it was like 10 to 20 pounds over the 3 months.
Does this move you guys toward any diagnosis yet?
I mean, at least it makes me feel reassured that he's stable right now. He's not like actually coming in with something like ascending cholangitis, at least frankly.
Yeah, it seems really chronic, as evidenced by the weight loss and kind of his history in general. The only other thing on his exam I wanted to point out was his respiratory rate of 20, which is kind of interesting. Seems to be breathing a little bit harder than somebody generally would.
Okay, let's go to labs.
Yeah, so for his labs, I'll give you the CBC and the CMP. So his white count was 2.8. His hemoglobin was 5.7. And his platelets were 55. And then for his CMP, his sodium was 138, potassium 2.9, chloride 110, bicarb 23, BUN 20, creatinine was 1.1. His baseline was at around 1, and glucose 109. For his CMP, his total protein was 5.7, albumin 4, T-Billy was 3.8, AST was 156, ALT was 46, and his alk phos was 60.
Any like fractionation with the Billy?
Yeah, so we fractionated it, and his D-Billy was 0.5.
Did you get the reticulocyte count?
Yeah, I didn't write it down, but I can look it up real quick.
Do we get a diff at all or a smear?
Yeah, so his smear showed rare schistocytes, about 0.5%, and then hypersegmented neutrophils.
It's okay if I jump in here.
Please, yep, I love it.
Okay. So first things first, as an intern, my reflexes replete the K. That's like the thing that you get trained on day one. So I'm kind of thinking first off the bat, like, you know, what do I need to do urgently for this guy with this information? So I think I would be, starting repletion of K and trying to get him some blood, packed red blood cells, just because his hemoglobin is so low. So that's the first thing that came into mind. And then to step out a little bit more. So with all 3 cell lines being down, what typically comes in my head with pancytopenia is like a bone marrow process. Obviously that's not always the case. You can have decrease in the individual lines for other reasons, but that's the thing that's kind of most coming to mind, which could be either an infiltrative process from kind of a systemic like autoimmunity, like that would be concerning versus like malignancy. So those are things that I'm thinking about. I had wondered if he was going to have an anion gap acidosis, which is why his respiratory rate was high, to try to blow some of that off, but I didn't calculate a gap. So I think that's a little less likely. And then his T-Billy being up, let's see, indirect, that says 0.5. Okay, so it's mostly indirect. So that is leaning me towards an extrahepatic process, more likely, or a prehepatic process, since the direct would be happening within the liver or post-liver. So I'm thinking a little more like on the hemolysis end from that perspective, and then with the schistocytes, that's kind of fitting together a little more there. I don't know if that makes any sense.
Yeah, that was really good. And then I can give some of the diff that I pulled up here. So like his monocytes were low. He had low granulocytes. His reticulocyte count was 1.8.
And did we get an LDH or haptoglobin or any other hemolysis labs?
Yeah, you can let me know what other labs you guys want. So his LDH was 6,000 and his haptoglobin was less than 10.
And so just to clarify too, the reticulocyte count, we generally tend to convert to an index, right? Because we have to take that in account with the hemoglobin, and that was low.
Yeah, so his reticulocyte index was 0.27.
Sneha, somebody in the comments asked a good question, which is what is the MCV? I don't see that up here yet.
Yeah, so his MCV was 109.
And then one other question was a Coombs test.
Yeah, so we got a Coombs test and it was negative.
These are some impressive labs. If I was in clinic and I got these labs back, this would probably be a situation where at least I would be thinking about TX before DX, or at least doing both at the same time. So I'm wondering if you called this gentleman to like either get admitted or did admit him for type and cross and transfusions and that kind of scenario as you were continuing to work him up.
And then if you guys want to talk through sort of your hemolysis differential and what treatments you might be thinking about, what more labs you might be thinking about obtaining, if there are people you want to call, etc.
One thing I would also just add is fibrinogen and everything.
Oh yeah, I can give his coags. His fibrinogen was 160. His INAR was 1.52. And then PTT was 25.
Did you get his folate levels and vitamin B12?
Yeah, so his folate levels, I didn't write that down, but I can also look that up real quick. For his vitamin B12, it was 73.
If I recall, I think the hypersegmented neutrophils is a pretty specific finding to B12 deficiency.
Sorry, his folate level was 2.
So when thinking about hemolysis, I generally divide it into the classic kind of intra-extravascular. Some people are touching on the intravascular etiologies, which are kind of like either microvascular damage from some of the kind of hemolytic anemias that are pretty common, HUS, those kinds of etiologies. And then we think about extravascular destruction with like reticuloendothelial kind of extravascular destruction. And so I would divide this, thinking about this, into that. And then I also think about the other cell lines that are down in all of this. So he has a lower white blood cell count and a lower platelet count. And to me, that usually is more concerning for something going on, like Natalie said, at the bone marrow level. And We also need to think about, is there an abnormal formation of red blood cells? And that's why they have a high MCV. And that's why people point out folate, B12, and so on. And so with all of this, my one inclination would be to really look into what would tie in all of these cell lines being low, and then also the macrocytic anemia.
And just to add to that, I feel like there are multiple different ways to break down anemia itself, but as Tijana had alluded to, you can break it down by MCV and begin to form your differential that way. So microcytic, normocytic, and macrocytic.
Somebody asked if there are any blast or immature forms seen on the differential, or sorry, on the smear.
There were no blasts seen on the smear.
And then, Mike, I wanted to point out something you said earlier, which was sometimes you have to approach a patient with the thought process of TX before DX, so treatment before diagnosis. And so are there any conditions that come to mind when you see labs like this where that may become the case?
I feel like I have the spotlight of stupidity on me right now, but as far as, I mean, I guess my initial TX would be thinking like with a hemoglobin of 5.7, I'd be thinking about transfusing this patient. With the white blood cell count, the leukopenia of 2.8, I'd be curious what his ANC is to make sure he's not also neutropenic. And yeah, with the platelets at 55, I mean, my biggest concern is like, is he going to show any signs of bleeding? Because certainly that would change my threshold for wanting to try to reverse his coagulopathy with his INR, consider transfusing platelets if he has any risk for bleeding actively. That's all I got.
Yeah, those are great thoughts. Anyone else?
Sneha, I want to ask our panel, what do you make of the rare schistocytes? And I don't want to take us too far down the wrong path, but you know, schistos scare us, as they probably should. So what do you think when you see that?
I think my one thought is that you have such large cells that they're being destroyed just because they're so large with an MCV of 109.
I also think of just like microangiopathic hemolytic anemias then, like, is that something we need to be worried about? I think of that less so with a pancytopenic picture, though I don't know if that's totally correct. And then I guess other things like we don't have on here are spherocytes or other causes that would lead you to a hemolytic process. So I think the absence of that is helpful in terms of like, there doesn't seem to be a membrane problem for these red blood cells.
That was great. Thank you both.
And then what about thinking in terms of a hemolytic process with the schistocytes? So we have MAHA, right? Microangiopathic hemolytic anemia plus thrombocytopenia. So what is the diagnosis that we can't miss, which is life-threatening? Yeah, Ben asks, how is his mental status?
I'd be worried about TTP.
Mm-hmm.
Yeah, that was one thing we were initially concerned about. His mental status was normal. He didn't he was alert and oriented, and neuro exam was normal, as I mentioned above.
What other things for you guys, Anita, during this case? Because looking at those labs, I think before having seen the B12, TTP would have been something I'm worried about. And in that case, right, at MCS 13 level, you can send, but that takes a while to come back. And so we often do plasma exchange for these patients, also called plasmapheresis, before that's confirmed in conjunction with our hematologist and our renal docs. And so what sorts of things were you looking at with this case, and why didn't you go down that route?
Yeah, I think we were reassured with just his clinical picture. Like he didn't have altered mental status, his renal function was normal. And I think also just looking at his reticulocyte index, it was low. And so I know with TTP, usually you'll have a higher retic index because your bone marrow is trying to compensate. I think we were more concerned when we consulted him, we were more concerned about like an underlying malignancy, given his kind of significant bone marrow underproduction. And so we were like considering doing a bone marrow biopsy on him.
And then, you know, our discussants already at the beginning of this case pointed out astutely that they most strongly feel that this is a somewhat chronic, subacute to chronic process, right? And TTP really can't be a process like that. That's an acute process. And so you guys already sort of pointed that out to us, and appropriately, that becomes much lower on your differential. The other thing is too, if you're truly thinking about the pentad, the patient also didn't objectively have any fevers.
Yeah, he only noted subjective fevers and like the night sweats that I mentioned, but he was afebrile when throughout his hospital course.
So for Natalie, Mike, and Tijana, sort of going with Tijana's thought of how are you going to tie this all together, if you guys had to put your nickel down on the one process that may tie this patient's presentation together, what do you think?
I think in the chat box I mentioned pernicious anemia. That's one idea. Yeah.
I'm still pretty concerned about like potentially an infiltrated or malignancy process within the bone marrow, or like even MDS or something like that could lead to this. I'm not really putting my nickel down. Sorry.
I'm leaning more towards like the nutritional deficiency causing the pancytopenia, leading to like the macrocytic anemia, and then hemolysis with that. Pernicious anemia would definitely be high on my radar now that Tijana said it. And actually, I think we may have been working together at Denver Health when we had a similar case to this.
Yeah, learning from experience on the wards. So yeah, and I think part of it is that there's such large red blood cells, and you're basically impacting how well you produce the other cell lines, not only from a nutritional deficiency standpoint, but also just like a structural standpoint in the bone marrow. That's just that.
I wanted to see if some of our attendings had any additional teaching points for this case before we move into case conclusions.
Sort of interesting interested in what Dr. Albert is writing there.
Yeah, I also saw that comment. That was also surprising, and I can talk more about that in a little bit.
Rick, do you want to explain that for everybody? Mind?
I was muted. With that very low B12 level, I was surprised he didn't have any peripheral neuropathy complaints, posterior column specifically. Pernicious anemia, or I mean, it may not be pernicious anemia, but I think this is B12 deficiency. Only other thing I could maybe think of, if he's got maybe some sort of leukemic involvement of the bone marrow with resulting hemolysis. But I think this is nutritional.
Great.
It's also a little surprising he doesn't have any GI symptoms.
Sorry,
Anita,
what's the normal B12 level? I don't actually know that.
Usually it's like greater than like, I think it's like 400, 500.
Yeah. Anything less than 200 is really bad.
Ah, okay. Did not realize that. Good to know.
And Sneha, you were gonna say something?
Oh, I just wanted to sort of let everybody give their thoughts and then for you to tell us the diagnosis.
Yeah.
Yeah, I was putting my comments in the chat box. I think as PD, I'm supposed to look smart here and say something, but my comment was just that I sent just to Tijana, which says, "You're so smart."
Oh.
So I'm gonna go ahead and leave it at that. I love that you've seen this and are applying it in real life.
Love it. Okay.
Oh,
Go ahead, Dr.
I
Albert.
like the Sabin's comment that this may relate to his hemicolectomy. I like that.
Mm-hmm.
All right. Well, I'm going to take over here. I just have a couple of slides, but Anita, tell us what the diagnosis was.
Yeah, so after consulting with heme, so they were actually going to do a bone marrow biopsy on this guy and then recommended we order the B12 and folate labs. And then when they saw that his B12 level was 73, they were basically like, all of this hemolysis, pancytopenia is secondary to his really severe vitamin B12 deficiency. And so with we got intrinsic factor levels because we were concerned about a pernicious anemia, and it was elevated. It was 160. And then in the setting of his history of the right hemicolectomy, we were like, okay, this is all just significant B12 deficiency from those things. So he had pernicious anemia, and I think the right hemicolectomy didn't help as well. And then just to point to Dr. Albert's comment with he had no posterior column findings because he had like a negative Romberg. And so after discussing with heme, and then Dr. Stabler, she's one of the heme onc doctors at the university, and she wrote like a great B12 article that's published in the New England Journal of Medicine. And what I learned from them is that the lower your B12 is, the less likely you are to have neurological findings, which I thought was interesting. Yeah.
That's very interesting.
Yeah. So she has like a great 10-page article in New England Journal of Medicine, which I would recommend reading.
Great. All right.
That was her article. I think that was Sally's article. Sally's table.
Yeah, it is Sally's.
Yeah.
Awesome. Okay, well, I just have a few quick teaching points to make here. Thank you all for participating and our discussants for getting the case cracked. All right, so the objectives really for today's case was to identify patients with hemolysis, right? When you see the presence of anemia, jaundice with a low haptoglobin and elevated LDH, consider hemolysis as the primary cause. And if you're seeing just anemia with jaundice, making sure that you're getting these extra hemolysis labs. We are recognizing severe B12 deficiency, and we'll talk a little bit about the presentation here, which was the pseudo-TMA syndrome. And then finally, we'll use a risk stratification tool to think about when we really should be considering TTP versus when we should be considering some other causes for patients' hemolysis. So I'm going to just talk about vitamins a little bit here. The term is combined vita and amine, life and amino acid. In the 1920s, when they first discovered thiamine, they thought that all nutrients had an amine group in them. Turns out that's not true. Vitamin C doesn't have an amine, so they decided to drop the E and we got the word vitamin. Vitamin B12, also known as cobalamin, is actually our biggest vitamin, is essentially ubiquitously found in the body in every cell and is a part of many cellular processes. And so just to point out that it's crucial in DNA synthesis as well as myelin production. And so if you guys can imagine with impaired DNA synthesis, you get a megaloblastic anemia and sometimes cytopenias. And then with abnormal myelin production, this is where really the patients get, like Dr. Albert pointed out, dorsal column deficiencies, which result in paresthesias, spinocerebellar tract impairment, which results in ataxia, and then lateral column can sometimes also be affected, which can cause weakness. And so here, though, we're seeing an even more substantial vitamin B12 deficiency. And when B12 gets really low, you get a ton of poorly produced, quickly produced red blood cells, which enter in the bloodstream, often with their nucleus in them, which is not supposed to happen. You get this megaloblastic features in your neutrophils, so your polysegmented neutrophils. And it really is, as somebody pointed out, it's the size of these cells and the poorly formed nature of them, which causes them to lyse, which can present as schistocytes. And so the diagnosis here really is a pseudo-TMA due to severe B12 deficiency. And just to remind you all that TMA are thrombotic microangiopathies, and really are a primary group of diseases. Most commonly, we think of TTP and HUS, and there are a couple other genetic and drug-induced TTP conditions in that, but it's really a small subset of diseases. TMA is described as a condition in which you have a DAT or Coombs negative hemolysis. So this is not an autoimmune hemolysis. You have schistocytes because of the shearing, and then thrombocytopenia. And then in order to diagnose a TMA, you can't have any underlying conditions. So DIC, which you astutely asked to rule out in pregnant women, HELLP syndrome, and then patients who have severe hypertension, rheumatic diseases, and some other conditions can also have hemolysis, but they don't have a TMA syndrome. And so here I'm just pointing out a nucleated red blood cell and some sort of cell, which is difficult for me to identify since I'm not a pathologist. And here's a schistocyte down here. A comment that I think I may have heard from Natalie earlier, and I just wanted to clarify that this sort of megaloblastic feature, which really means hypersegmented neutrophils, only occurs in nutritional deficiencies, so folate and vitamin B12. And so because this patient had these hypersegmented neutrophils, they truly have a megaloblastic anemia. And not to say that you can't have a bone marrow process like MDS. Perhaps you can see hypersegmented neutrophils, but when you see that, you truly have a megaloblastic anemia, which is a result of nutritional deficiencies. The patient can still have, patients on the right side here normally have a macrocytic anemia that is non-megaloblastic. And so, you know, one last question here to ask, which we've somewhat discussed already, is how do I know whether I should text this patient or they just need a shot of B12? And so something that I learned as I was preparing for this case is this plasmic score, which I hadn't used before. And so this score really is used in hospitalized adults that haven't undergone PLEX yet to think about what is their risk for TTP. It predicts how low your Adams TS13 deficiency is. And so for this patient, I inputted this patient's information in the plasmic score, and this patient's score was low. And in fact, this calculator tells you that this patient had a 0% risk of a severe deficiency. And so with his time course of illness, the low vitamin B12 level, and the low reticulocyte index, our suspicion for TTP should be quite low in this patient, and appropriately he did not receive. The other question to think about here is, you know, we often tend to hang our hats on schistocytes and attribute them to certain conditions like TTP, other TMA processes. And so to ask yourself, how good are schistocytes in diagnosing or helping you diagnose TTP? So this study was done in pregnant women that had HELLP syndrome, to also look at whether they were transforming into a TTP-like condition. And as you can see, the higher your percentage of schistocytes in the blood, the higher your likelihood ratio that it's TTP with, if your schistocytes are greater than 1.9%, that's a likelihood ratio of 60, so that's astronomical, right? And your post-test probability would be incredibly high for TTP. Normal value is generally quoted to be less than 1%. So less than 1% is typically normal. There are a few case reports of TTP without schistocytes on smear. And so just remembering that the absence of them does not rule it out. And if you have high enough clinical suspicion, they have the other findings of the pentad, consult with your hematologist and get them treatment early. And so for this case, our conclusion is that this patient has severe B12 deficiency, as many of you identified. He had elevated autoantibodies and a right-sided hemicolectomy, which both contributed. He was treated with IM injections of B12. 10 days later, his CBC had improved, normal white count and normal platelets with an improving hemoglobin. 3 months later, his CBC had completely normalized. He continues to receive B12 injections. And then for most of my talks, I like to incorporate healthcare disparities. And so I wanted to talk a little bit about healthcare disparities in nutritional anemias. And so when we think about anemia in general, it has a higher prevalence if you're of American Indian or Alaskan descent with a significant odds ratio of 4.5. And if you're Black or Asian, you're more likely to have anemia as compared to your white counterparts. B12 deficiency is more common in Asian people, and then overall in elderly white patients due to higher rates of atrophic gastritis. And then folate deficiency, again, more common in American Indian or Alaskan natives. But as you guys know, nutritional deficiencies and anemias are actually one of our easier conditions to treat. We have tons of affordable nutritional supplements. B12 comes in many varieties of pills and injections. And these anemias are quite easily treated. And so the reason I'm presenting this today is just for us to recognize in the back of my mind that we should be screening some of these higher risk groups more often and then treating their anemias appropriately when we do discover them. A lot of these discrepancies are thought to be also related to cultural and dietary preferences, but again, just recognizing that they do exist and that they are easily treated. And then wanted to give you some self-directed learning opportunities here. The first one is to identify what test I'm showing up here. And then something we didn't talk about today are autoimmune hemolytic anemias, and for y'all to read about what makes them warm or cold, etc. So I'll let you take a look at this test just for one more second here. All right, I wanted to see if you had any questions, and there is a feedback survey for our residents to see what other conferences you guys will like. But that's all I have for today. Thank you so much for participating.
Thank you, Sneha, and to the discussants. Hopefully that went really well.
Thanks, guys.
I think you all did a great job. I just want to say thanks from me too. Yeah, great case, great discussants. Loved it. Sneha, excellent, excellent presentation.
Thank you.
Good luck, applicants.
Yeah, and applicants, you all can stay here for just a second. We'll do our we'll do a little wrap up before you guys go.